glitch. I'm still wondering how that happened. So thank you for all the previous speakers who have set up the topic perfectly. So today I'm going to be talking about how we optimize our myopia clinic for our myopic patients. I know there's a lot going on in the myopia clinic, but when the patients do come, we need to organize and set in some systems and processes in the clinic so as to ensure that all the things that we spoke about are being followed. It's easy to miss in the hectic OPD the things that we actually want to do. So this talk is primarily going to be just the lessons that I have learned over 5 years of the myopia clinic that we've been running, and what we have learned and how we have taken it forward. So the lesson one is that the workplace is extremely important. So how you set up your place matters a lot. Is the sound coming from me? It's from the next one. Okay. So the workplace is extremely important because it's important to kind of set up a small space aside for the myopia clinic, because patients then know that you have a specialized practice, number one. Number two, it's easy to get the patients together to give the awareness. People who do myopia know that it kind of gets repetitive after a while, so you want to put them all together and then give the advice together. It kind of saves time that way. And third, whatever it is, visual aid helps. So when you want better uptake of treatments like atropine and DIMS and so on and so forth, they're quite expensive, some of them. So if you have good visual aids that can have these pamphlets and these things that are concentrated in one area, while the patient waits, they actually kind of get to see all of this. And the most important thing is that it's more efficient time wise. If you're able to put all of that together in one place, the patient gets to go to 111 next quicker. So the lesson number one that I would like to take from this is the workplace is extremely important. So we have the Kanmani clinic there, where the myopia clinic, which is primarily all our children go through this clinic, and they have all their awareness built into that system specifically. So this is the refraction room. Everything is built into that system, so children and parents know what they're getting into. And of course, we have all these pamphlets and these IEC activities that are built into the clinic itself. The second most important lesson that I had is the workflow. Now, it's very easy to kind of, do the refraction and then come back to us, but there's so much more in myopia that we need to do. So the first thing is identifying the patient, and the identifying of the patient has to be done by the ophthalmologist in the first visit at the end of the cycloplegic refraction. Before cycloplegic refraction, you cannot label anyone as a myope. So the first identification to be done by the ophthalmologist. So we train our ophthalmologists. We have a small team, so we train all of them on how to identify. The second is counseling. The immediate thing is to counsel them to schedule a second visit. I usually do all my myopia workup on the second visit and not on the same day, because they are better prepared. The next thing is enrolling the patient into the clinic per se. The next step, what I do is profile the patient. That is based on questionnaire, parental myopia, and so on. And the next one is the actual myopia workup or the clinical testing that we do. This is followed up by the slit lamp, the review, and the final recommendations by the doctor. From here, it doesn't end here. It goes back into counseling, where the child is finally given the final list of things that they have to do, and they're guided into the pharmacy or the opticals. Now, this is the kind of workflow that we follow in our small clinic, and it has helped us through the years to set up the systems. Now, when I talk about workflow, this is for the new patient, but when you have a review patient coming back after 6 months, or a myope who's already been diagnosed coming back for review, we start from this point. So we enroll them directly by the optometrist into the myopia review system. So this is how it goes. So I'm going to talk about each of this. So identifying the patient is most important, and as already elucidated wonderfully by previous speakers, the ophthalmologists have to be trained in this to identify myopes after cycloplegic refraction, lower than average myopes, the so-called pre-myopes, kids with parental myopia. Even though they are hyperopic, any kid with parental myopia, I enroll them into the myopia clinic. And the fourth, the children who are already on review with the myopia clinic. Now, these are the kids whom we identify to put them into the myopia clinic. The second is the actual patient enrollment. Now, we have a separate myopia clinic register where the optometrist actually enters by hand all the patients who are actually entering into the myopia clinic, and we automatically, the optometrist at that point includes them into the WhatsApp support group that we have, and the support group they get added into the whole process of the follow-up. So this is the enrolling patient. The third thing that they do is profiling. So immediately the optometrist hands over the questionnaire. Earlier we used to give paper ones. Now we have the Google form. We have a set of 32 questionnaire which we give to our patients, which covers all these aspects. We have the questionnaire. I'm ready to share with you if you can email me if you require it. So once we profile our patient, we have in all these aspects, the eye health of the family, reading habits, gadget habits, long holiday behavior, living environment, and eating habits. So all of this is covered in the questionnaire. Following that, we actually go into the workup part. Now, the workup part, I've split it into two because I know that not many setups have everything available and the expertise also available. So the recommended ones is definitely subjective refraction and cycloplegic refraction. We do a stereopsis, a Worth-Fodor test, and a cover test just to diagnose other abnormalities existing with myopia. Then, of course, the two important metrics that we do is the axial length and the keratometry, which I would definitely recommend for every myope on every visit at least 6 months apart. The optional tests are dynamic retinoscopy to detect accommodative lag. The second test that I would recommend is relative peripheral relative peripheral refraction, which is a newer concept that's come. The third is mesopic pupil size, corneal topography, and Schirmer's test. Now, these tests, if you have the time and the place and the person to do it, it can be incorporated into the practice. Now, this is just a small test to show how the accommodative lag is done. This is a MEM card. This can be attached to the head of the retinoscope, and then it's basically dynamic retinoscopy. So while the child is undilated and with the corrective refractive correction on, the optometrist or the ophthalmologist can actually do a quick retinoscopy. Anything beyond plus 0.75 is abnormal and needs to be considered as an accommodative lag. So this is how it's done. Once it's mounted on the child, you just have to ask the child to read out the letters or the words on there, and then you just have to do the refraction over it. So we just put plus 0.5 directly, and if plus 0.5 shows emetropia, then okay, you're okay. If it is anything beyond that, it's accommodative lag. The second concept that's recently come about that's really helping us in prescribing DIMS lenses is the concept of relative peripheral hyperopia. So the concept is that the globe elongation happens more along the posterior pole, thereby the periphery or the mid-periphery actually is a little hyperopic as compared to the posterior pole. So what we are looking at is to look for this kind of a with the movement. So there are, ideally you should be doing this with an open field autorefractor, but unfortunately we don't have one, and now the manufacturing has also been stopped for some of the machines. So what I do is really basic, but I think it gets the information and it's very simple to do. In an undilated fundus, all you have to do, keep the refractive correction on. You do the correction in the along with the thing and look for emetropia in the primary gaze. Ask the patient to look and fix straight. Now what I do is I move to the periphery. So once in the nasal and one in the temporal, and I look for with movement. That's all. If there is with the movement, that means obviously there is a peripheral hyperopia in the peripheral aspect. I do it for both nasal and I do it also on the temporal side. So with this you will get an idea whether there is a peripheral hyperopic reflex seen in the child. If there is peripheral hyperopia, they respond very well to spectacles, and that would be the first option that I would be offering my patient rather than atropine. So this is how we do peripheral, this is how I do peripheral hyperopic defocus. It's not very standardized, but it really gets the work done and gives me the information I require. Now, all the other tests I spoke about, if it is in a single area, it can actually be done really quickly, and ideally a myopia workup would take about 20 to 25 minutes. That's the efficiency that we are looking at, because we are looking at so many tests to be done, and if it's all in the same place, it can be done really quickly and efficiently just by a single optometrist. So the next thing is, of course, once they're done with the myopia workup, they come to me for the slit lamp, the review, and the final recommendations based on the testing that we have done. And with this, I give certain recommendations and then push them onto the counseling department. So the counseling gives the usual outdoor activity, visual hygiene, the routines, all of this is already covered in detail, so I'm not going to go into that. Additionally, what we give is instructions on the recommended treatment. The counselor is trained to do that, follow-up date, and also they are given a small myopia journal. Now the follow-up date is fixed on that date when they are actually going to leave the hospital itself. This is the small myopia journal with which we give all the information written down to the patient so that they can take it back. The next thing, so this is the myopia journal which we give and can be easily designed by anyone here. Of course, after that, they go to the pharmacy and to the opticals, and thereby they get their glasses or their drops or whatever is required to go further. So just a little note about the DIMS lens. So this is what we are doing. We've been dispensing some DIMS lens, and you can see this mid-peripheral plus lenses that I say that actually create a peripheral myopic defocus to counteract the peripheral hyperopic defocus. And we also have the Hall technology, which is actually creating a volume of defocus. It's basically a 360-degree multifocal, so progressive. So we did a small study. Can I take some more time? Okay. So we did a small study with the DIMS on 15 patients and 30 eyes. We followed them up for progression initially. So from baseline visit to the visit at which they were prescribed DIMS, we followed them up for progression, and then we followed them up 6 months later. So it's a really extremely short follow-up that I have, but nevertheless I wanted to present it. The mean progression of these eyes before the DIMS was prescribed was minus 0.67 diopters, and after the DIMS was almost minus 0.2. So we had almost 70.1% actual protective effect of refractive error with the DIMS lenses that we had prescribed. And in terms of the axial length, again, prior to the DIMS, the progression for the 6 months was 0.45 millimeters on an average, and after the DIMS, it was 0.05. So it has an excellent effect on the axial length progression per se, and the protective effect on axial length was almost 88.9%. So these kids, ideally, spectacle lenses I would recommend to be given to children who have peripheral hyperopic defocus. Just do a quick retinoscopy, nasal and temporal, to get a width movement, and if you have that, please go in for these lenses. They work really well. This is a chart that shows a number of kids who had no progression. So 45.8% actually did not progress at all in the 6 months. 83% progressed barely 0.25 diopters, and 12% actually were non-responders. Now, when I go back to these patients, they probably weren't hyperopic in the periphery to begin with. So these are the pros and cons of spectacle lenses. So the pros are it's non-invasive, there's a lot of comfort, there's good compliance, and you can actually use them for pre-myopes because they're really non-invasive and they work pretty well. The cons are, of course, it's not good for more than 10 diopters of combined refractive error, and the refractive index of these lenses are quite low, so they have little thick lenses, and there's only a binocular option available currently, and of course the cost is a huge limiting factor in these spectacle lenses. So when it comes to progressive myopia, usually I call the active lifestyle monitoring as the sumo wrestler. He's the big guy of the myopia control. Everywhere, every place we talk about it. Dilute atropine I use it for patients who are fast progressors, aggressive progressors, because atropine works beautifully well. He's like these real wrestlers that are there. DIMS works as these more like these WWE wrestlers. They're like going all over the place, but they still work. And the PALs and the multifocals are like sharpshooters. If you have accommodative lag, then they work perfectly well. So they're very high specific indications they work in. Okay, so that was the second lesson. The third lesson is we need to train our parameters, our personnel. So the first is ophthalmologist has to be trained, a counselor has to be trained, an optometrist has to be trained. We have to train our pharmacy and the optical sales, and last but not the least, our advocacy manager. These are the 6 people I have on my team for myopia control, and they kind of work together in tandem, and we have our regular meetings for training. The lesson number 4 is we also do a lot of academics and research. So we have weekly meetings, we have review of ongoing studies, and we also have classes for PGs and fellows. And the last but not the least, the 5th lesson is the most important, which is advocacy. If you want patients walking into your clinic, you would want to have school screening camps, and that's the only way you're going to get a lot of patients to walk into your clinic, because you want to build your clinic, you need to do school screening, you need to do a lot of awareness activities around your area, and set up a really established referral system. So this is us doing a school screening camp in the nearby locality, and this is us doing a drawing competition just to increase awareness on myopia. So systems and processes are essential to keep the crusade, but they should actually not replace the crusade. We should be passionate about myopia. The ultimate thing is to counter myopia at a very, very early stage. Thank you so much for your attention, and this is to bring Myopia Masterclass 2. We are having it on Sunday. I request all of you to join at 10 a.m. at Jade Hall. We'd love to have you there to discuss case-based strategies. So this is theory, and that's going to be a lot of practical information. Thank you.
One question, madam. Yeah. One question, madam.
Yes, sir. Please go ahead.
We started about 40 years back school eye screening, visual screening for school children.
Yes, sir.
At that time, myopia was the main target point. So we trained teachers in detecting myopia and referring it to ophthalmologist. Now we want to start myopia clinics in all optical shops. That is a big program that is going on. What is your opinion about it? See, children constitute primary school and middle school children. They constitute 40% of population. Athara. So, myopia is an easily detectable and manageable disease, manageable ocular problem in children, visual problem. So, how do you suggest for this MOS program covering school children who constitute 40% of population?
What is the question? I didn't get it.
Sorry, are you recommending that optical stores take up myopia control clinics? Okay.
I mean, you can respond if you want to. Anybody wants to respond? Or I can respond, whatever.
As long as there is an
Mulani
ophthalmologist
Opticals,
at the helm
Baliwala
of
Homi.
affairs.
Mulani Opticals, Baliwala Homi, and Ben Franklin, they are starting myopia clinic.
Yes, sir. So, if there is an ophthalmologist or a really trained pediatric optometrist at the point to take care of things, then definitely yes, it may be a good option. But without a trained ophthalmologist or a pediatric optometrist, ophthalmologist, if you're going to be prescribing atropine, because it's one of the most important treatments available, and pediatric optometrists are trained to give out spectacle lenses and orthokeratology. So optical stores, those who have only salespeople, definitely wouldn't recommend it, but I would recommend an ophthalmologist or a pediatric optometrist. If they are in charge of the clinic, then it would be a good idea.
I'd like to answer that as well. The problem
I have come
here with
across quite a few
opticals-
patients.
Sir, she is responding to your question.
Only one question. It is over.
No, let her respond to your first question.
No,
Yeah.
I speak also to the public. The problem when optical stores take up myopia detection and myopia treatment is that they have a big conflict of interest. They are the ones who are selling the glasses as well. So then what happens is that we will have an increased detection level of myopia. We may also not have a good cycloplegic refraction. We will get lot of pseudo myopia. They will be aggressively selling dims. See, we have like how Shruti said, we are going to work them up. We're going to tell them environmental control, do this. As an ophthalmologist, we are trying to dissociate ourselves from selling the spectacles. But it is as good as saying that the cancer drug seller is going to now treat the cancer, or someone who is the glaucoma seller, like the glaucoma eye drop seller, is going to treat the glaucoma. So we do not want that, because this could, I know it makes sense that yes, there are so many optical stores now, then all of them are going to be helping children from myopia. But what might really happen is that they're going to overdiagnose them, oversell their spectacles, and then at the end of the day, it's going to be fear-based marketing that start doing this atropine drops. And then what is going to happen, what is already happening, is that general ophthalmologists take this eye drops, which is very easily available, and they are being pushing minus 0.5 people who are pre-myopes, everyone will be on myopia eye drops, in that fear-based thing that okay, start this drops, otherwise your child will get myopia, wear these spectacles, otherwise your child will have myopia. So that is not the that is why we have these conferences where we want to reduce the fear-based treatment of a disease that can be controlled very effectively without having that's my thing, that we don't want optical stores. That is the only reason why I would not suggest having optical stores as.
Can I add a point to that? Yeah, since we're talking about myopia progression, in optical shops, you don't really know whether the child has progressed or not. They would end up giving this to all the new myopes as well, which is not what we're talking about.
Exactly.
We don't need to be giving this to all the new myopes. We don't need DIMS for them. We don't need atropine. We don't need any of these treatments. It's
So we
only
are
for
not-
progressive myopes.
So the point which she's making is that we are talking about myopia progression, not
Yes,
myopia. Myopia is
exactly.
fine. Myopia is being done by everybody. It is perfectly fine.
And
We're
it is
just talking
us,
about myopic progression.
and it is us who define the myopic progression. It is not them. Even if it is increased by 0.25, they may end up advocating it, but we are not going to be doing that. So we're going to be taking all the lifestyle factors into account, then the progression, and then the other risk factors, and then deciding on what kind of treatment the child may benefit from. So I think that's why we play more of an important role
Yeah,
than
that's
just the optical people.
So I think our next talk is absolutely bang on.
So I
for
got
this.
just
So
two more
can we take
questions.
after the
1 minute, I'll finish it off, half a minute. I come across a lot of early myopia patients with a psychiatric problem. It confuses between whether it is ophthalmic case or a psychiatric problem, and how to manage those cases.
So we'll be dealing with that on
That is done
Sunday.
in immense.
We'll be dealing with that on Sunday. We have a special segment just for this
for
case
that
based,
only.
which is going to take
What about
one-
night contact lens used by Japanese in the management of myopia?
Sorry?
Night contact lens. You put contact lens in the night, remove it in the morning. That
Oh,
Japanese
autokeratosis.
say that
Autokeratosis.
gives the best results.
Again, sir, something we'll be talking on Sunday. One more session is just for this, these 2 points.